In this final diabetes lecture, what we're going to talk about are the diabetic emergencies. That is, what happens when you go too low, hypoglycemia, and what happens when you go too high for too long, DKA and HHNKC. Let's start off with hypoglycemia, because remember, one episode of hypoglycemia can kill a patient. So if you are a diabetic and you get hypoglycemic, it can be from a lot of things. And it's usually lifestyle or medications. Right? We might do it by giving them too much insulin or by giving them too many medications. They might do it to themselves accidentally by either exercising too much or exercising more than usual or by eating too little. Or it could be something much more sinister, like sepsis. But regardless of the cause, if it's a diabetic who's hypoglycemic, what you want to do is just fix it. And so if they're awake, give them an oral glucose load. It could literally be oral glucose, or it could be jelly beans, a candy, a fruit juice, or a non-diet soda, something with rapid acting carbohydrates. And they keep checking until they get back into normal range. If the person's in a coma, because they're so profoundly low, you don't want to put glucose in their mouth, they'll aspirate, you give them IV in the form of D50. It should be considered an emergency, right? Calling 911 for someone who's hypoglycemic and passed out is legit. That should happen. The thing is that the patient, though, usually knows, right? So the patient might feel their hypoglycemia before they check, and that presents as palpitations, diaphoresis, presyncope, and it will progress eventually to coma if you let it. The diagnosis is made by checking a blood sugar. And a blood sugar less than 70 is the number which says, hey, that's a true hypoglycemia. And the treatment is just simply correct it. But then you follow up on what caused it. If they need less medicine, scale back. If they just need to know that what they're going to do, heavy exercise, they need to carry some sort of nutrition with them, that's okay. But you have to find out what happened and why they got that way. And less than 70 is considered hypoglycemia. But some patients don't feel hypoglycemia at less than 70, still call it hypoglycemia for the test, but they might be able to handle a little lower blood sugar on average. And the other way, if people are used to having very high blood sugars, if that person experiences hypoglycemic symptoms at a number higher than 70, it's still hypoglycemia. Call it hypoglycemia and get their sugar up. You don't want the blood sugar to go too low. That can be fatal. So, diabetic and hypoglycemic, find out what it was that caused it and correct that, but immediately get their sugar back up. But what happens if they're not a diabetic and they're hypo? This is true hypoglycemia now, right? They have the symptoms and the blood sugar to prove it. Not just, oh, I'm feeling hungry, I must be hypo. No. They actually have the symptoms of hypoglycemia and their blood sugar is less than 60. This can come from two things. There's more than this, but these are the ones I want you to see. An insulinoma, which is super rare, and it's almost never going to be the case in real life, but you might see it on the test because it's a pretty good diagnosis to see on an exam, or the person's simply faking it. It's factitious. Now, there are other diseases that will do this, but we're not going to talk about them. What you're looking for is, are they faking, or do they have the super rare tumor that you need to diagnose? You do that by getting a couple of tests. You wait for them to be hypoglycemic, and then you check, because the blood glucose has to be low. You get a C-peptide, a proinsulin, and a secretagogue screen. All right, this is what we're doing. Here's the pancreas. And we know that proinsulin is packaged with a C-peptide, and then insulin is part of proinsulin. If this is coming from the pancreas, that is endogenous production, what should happen is when there's too much insulin, you should also be able to measure excess C-peptide, because it breaks apart to form insulin. So if it's coming from the body, C-peptide should be elevated with insulin being elevated and the blood glucose being low. Therefore, if the C-peptide is not elevated, but the insulin is and the glucose is low, they're faking it, they are injecting. They're injecting exogenous insulin, and you tell them to stop doing that. If the C-peptide is elevated, then you know there is endogenous production. They're not injecting, but they still might be faking it. So what you need to do is a secretagogue screen. Because remember, the oral anti-diabetic medications like sulfonylureas induce insulin expression. So if someone downs a bottle of sulfonylureas, they may have hypoglycemia from too much insulin. So if the sulfonylurea screen is positive, they're ingesting. Tell them to stop doing that. But if the sulfonylurea screen is negative, now you're thinking about an insulinoma. With an insulinoma, you want to do a 72-hour fast. Bring them into the hospital. Do this process again. Wait for them to get hypoglycemic. Once confirmed that they indeed have an endogenous production, get the CT or the MRI of the abdomen in order to diagnose it. Remember, there are other diseases that cause hypoglycemia in a non-diabetic patient. Where you want to go is separate factitious from insulinoma. If the C-peptide is low, they're injecting exogenous insulin. If the sulfonylurea screen is positive, they're eating sulfonylureas. Just tell them to stop doing that. If the C-peptide is high and the secretagogue screen is negative, then you can consider insulinoma or those weird antibody diseases. I'll put up antibody diseases here, but I want you to not learn them for this test. That's too little. What happens with too much? DKA, diabetic ketoacidosis, is the disease that type 1s get. Now, of course, I'm going to say this. Type 2s can go into DKA, but what I want you to learn is type 1 DKA, type 2 HHNKC, also called HHS. In DKA, what's happening is there is a lot of sugar circulating in the bloodstream, but there's no insulin. So even though all that sugar is floating around in the blood, none of the cells can get access to it. So the body thinks it's starving. So it causes fats to break down and releases ketones. Those ketones cause ketoacidosis. But at the same time, because someone has intact kidneys, that high level of blood glucose in the blood means there's a high level of glucose in the urine. The Tmax of the tubules is only about 180. And so when the person is going into DKA, their blood sugar is high, the amount of sugar that's in the urine causes a massive osmotic diuresis. These patients become profoundly dehydrated in addition to their acidosis. So what you're going to see in the patient presentation is diabetes, but it's going to be a diabetic coma. They're going to be altered. They're going to have ketones, and they're going to have acidosis. Thus, diabetic ketoacidosis. The diagnosis is made to reinforce just that. You check a blood glucose, and generally, type 1s don't get very high. It's usually 300 to 500 is going to be the typical DKA glucose range because they get so sick from the ketones and the acidosis, they don't have time for their sugar to get very high. If you check the urine, it would be positive ketones, which is enough. The test might ask you to check serum levels, which is appropriate, but most of the time you have to wait for that test to come back in real life. So if the test asks you for serum ketones, that's the better answer. But in life, know that your analysis is usually sufficient if there's positive ketones. And you get an ABG. which shows acidosis. These patients are usually obtunded and have significant vital sign derangements. You can stratify DKA in mild, moderate, and severe, but if you say DKA, I say ICU. And the one thing you do before you get to treating them is get a BMP, because you want to know what the gap is, and you want to know what the potassium is. Because the treatment for DKA is look up the DKA protocol, follow the DKA protocol. It's really easy to manage DKA. What you have to know is, what do you look for? The nurses will do most of this for you. But you, learning about DKA, have to know you need to watch the glucose, the potassium, and the gap. To treat glucose, they need insulin. And usually you give 10 units of IV insulin, followed by an insulin drip. And of course, as you treat them, you're going to check the blood glucose. But before you give any insulin, you need to check a potassium. To check a potassium, you need a BMP. If you remember from our hyperkalemia lecture in the renal section, we used insulin in D50 as a means of temporizing hyperkalemia. You give IV insulin, potassium is going to shift into the cells. If you have hypokalemia, you're going to make it worse. So before you give any insulin, make sure the K is above 4. And replace the potassium every time you see it being low based on the BMP. Now the gap is going to be fixed by the insulin. But remember, these patients are profoundly dehydrated, so you're also going to need to help them with that dehydrated state. So you're going to bolus the shit out of them. Vigorous hydration with either normal saline or lactated ringers, it doesn't matter which one you pick. But you're going to follow the gap with the BMP. Because what might happen is the sugar, the glucose, might get down to normal ranges, but the gap would still be open. You stop ICU level management when the gap closes. So if the insulin drip is running, you need to continue that until the BMP shows the gap closed. While the insulin drip is running, the blood glucose might get too low. So after you've bolused the crap out of them with normal saline or lactated ringers, as the gap remains open but the glucose starts to fall, you change to D5, half normal. You give them the sugar so the insulin can act on the sugar to close the gap. Once the gap is closed, you bridge with long-acting sub-Q insulin, get them off the drip, let them eat, see what happens. Gap reopens, start over. Gap remains closed, they go home. And you have to remind them that, hey, if you don't take your insulin, you're going to go into DKA. But other causes of DKA could be an NSTEMI or infection. So don't just say, hey, this person's non-compliant. You have to find the reason why they went into DKA and treat that in addition. Now, this is for type 1s. Type 2 goes into hyperglycemic, hyperosmolar, non-ketotic coma, also called HHS. The pathology here is that it happens to type 2s. And the same thing is happening. So you're going to present the diabetic coma. They'll have diabetes, they'll be altered. But there's no ketones and there's no acidosis. Because type 1s have no insulin, they go into DKA. Type 2s have a little bit of insulin, so their cells are still getting the energy they need, but their sugar just keeps going up. And the problem with that is that they don't present acutely. No acidosis, no ketones, no super sick right away. But these patients have really high blood glucoses, and so their osmotic diuresis is even worse. So they are profoundly dehydrated. They still may present with coma, but you're not going to see ketones or acidosis. The diagnosis is going to be made by getting a blood glucose. And here you're going to see 800 to 1,000. Just because it's under 800 doesn't exclude the diagnosis. I just want you to feel HHNKC, very, very high glucoses. DKA, usually not that high. And the urinalysis is going to be obtained, no ketones. You're going to get an ABG, no acidosis. You're going to get a BMP. You want to check for a K and a gap, but the gap will be negative. And the treatment is the same. They need lots of fluids and IV insulin. They need much more fluids than the DKA. But there's no gap to follow. So it is possible you treat an HHNKC on the floor. Not something you'll have to make a decision about on the test, but I want you to see is that these diseases are equivalent. They are both profoundly dehydrated and both very ill, and so should probably be observed in the ICU on an IV insulin drip, both getting tons of fluid. Okay, we talked about the diabetic emergencies, hypoglycemia in a diabetic, find out what happened, but more importantly, get their sugar back to normal. Hypoglycemia in a non-diabetic, they're probably faking it either with insulin injections or secretagogues. Figure that out, and if it's negative, go after the insulinoma. And the way we separate them is with the C-peptide and secretagogue screen. Then the hyperglycemia, DKA is diabetic ketoacidosis, very obvious to spot because there's diabetes, ketones, and acidosis, treated with fluids, potassium, and IV insulin until the gap closes. HHNKC is profound dehydration in type 2, no ketones, no acidosis, but very, very, very high glucose. They need a ton of fluid and IV insulin. That is the diabetic emergencies.